So I am me, Søndergaard, and as Maria mentioned, I have studied and am studying healthcare seeking for different gynecological disturbances or gynecological problems. And this talk is based on some research I did in connection with my master's thesis, specifically on healthcare seeking for and diagnostic delay for endometriosis in Denmark. So in this presentation, I will focus on healthcare seeking behaviors, or how women seek healthcare and why it might be hard for them to seek care. So in line with, of course, the other two talks, but that's of course also why we have a webinar. We have like a lot of interconnections between the talks. But I just wanted to say that, or to recognize that many women are feeling incredibly dismissed, like many endometriosis patients are being dismissed by healthcare providers, and that is a huge problem. It has significant consequences for their lives. And I have also done something on diagnostic encounters, but that's not what I'm going to be talking about today. I am going to be talking about that part, which we sometimes call patient delay. So why you might not go to the doctor. So the overall argument here is that the symptoms of endometriosis, as well as the social norms around those symptoms, are quite significantly contributing to the diagnostic delay. So it's not just that women are dismissed, even though that's a significant factor. It's also the symptoms in and of itself are problems, that they're not great for minimizing diagnostic delay. So why did I do this study? Like, why am I interested in healthcare seeking and symptoms? So what I'm interested in is the anthropological perspective on healthcare seeking. So usually within medicine, there's a tendency, or has at least been a tendency, to see healthcare seeking as a quite straightforward process. So you feel something in your body, a symptom, and then you go to the doctor. Seems pretty simple. But in reality, it's more like the bottom diagram I've drawn here. It's not the top. It's quite a complex process to figure out whether something's a symptom. So we feel all sorts of bodily experiences, sensations in our body, pains for different reasons, and we continuously have to figure out whether we think these are medical concerns, whether we should consult a medical professional about them, whether they're worrisome, basically. And so I tried to go into this messiness of trying to figure out whether something's worrisome in this study. So here I'm kind of also trying to bracket the idea that patients fail to recognize some symptoms, or that doctors fail to diagnose patients, but rather looking at what makes it hard? Like, is there good reasons for why you might not seek care, for example? And of course there is. That's the quick spoiler. There is good reasons. So what am I basing this on? As mentioned, it's my master's thesis research, but how do you study the messiness of healthcare? Of course, because usually when we study diagnostic delay, we study it retrospectively. So we interview endometriosis patients about their diagnostic experience and look at, so how was it? How did you get your diagnosis? When did you seek care? But when we look at illness narratives retrospectively, they're often structured in a specific way. So when we tell stories, we naturally try to structure them having a beginning, a middle, and an end. Which kind of indicates some kind of coherence or causality. It makes it very neat and linear as a process. And anthropologists argue, well, this is a lot more messy. It's a lot more back and forth. And I wanted to get into that mess. So how to do that? Well, I did fieldwork among young women in their everyday life. So these are not women who have endometriosis. These are just teenagers who have periods. And fieldwork is both interviews, but it's also observing. So I'm basically just hanging out with people and seeing what they're doing in their everyday life and how menstruation sort of plays into their everyday life. And I'm try to look at how healthcare seeking considerations unfolded in everyday life. So to do that, I followed a class of students, upper secondary level students in Denmark. One class was 19 young women in this instance. They were between the ages of 17 to 19, and they were not as diverse as the samples that, or as the people, not samples, as the people that Maria and Eileen work with, these were white, cis, middle-class young women. So not as diverse, but it's slightly different methods. And then I also did interviews, retrospective interviews with patients who have endometriosis. And I did interviews with 11 patients where I interviewed them all except one, 2 or 3 times. And those were quite long interviews about everything, about their whole menstrual history and how they related to the diagnosis and how the diagnostic process unfolded. And these women were older, so they were 20 to 39 years old, and they've all had their endometriosis diagnosis within the last 5 years, so relatively recently. They were also cis, they were also white. There was a little bit more lower class women, I would say working class women, but mostly primarily middle class still. And they were recruited with help from the Danish Endometriosis Association. So I had these 2 data sets, and then I tried to merge them to see what I could learn about healthcare seeking by going back and forth between the 2 data sets. So the data collection ran parallel. So I kept going back and forth asking questions to the endometriosis patients that I got from the young women, and the opposite way around. All right, so the first thing I found is that menstrual pain on its own seldom leads to an endometriosis diagnosis. And I wanted to know why. Like, why can't that symptom on its own lead to a diagnosis? So the first reason is very much in line with what Maria says. So the idea that menstrual pain is normal. Menstrual pain is not considered a symptom. It's not considered indicative of disease. So brought to you here like an excerpt from online information you can access in Denmark. So the Danish health authorities have like a web page where you can look up different symptoms and diseases and stuff. And this is some of what it says, that it's completely normal to have menstrual pain. So if you look up information as a young woman, that is what you might find. And it's also a quote from one of the endometriosis patients in the study, Simone, who was told by her GP, so her general practitioner or family doctor, that her menstrual pain was normal. That's normal. That's how it is to be a woman. It hurts. And this sentiment was also repeated by her mother. And then I wanted to ask why again. It's a problem we have as anthropologists. We keep asking why. And so the next why I was asking, okay, but why is it considered normal? And I often ended back at the prevalence of menstrual pain. So the fact that it among the people I worked with were more common to have some form of menstrual pain than to be pain-free during menstruation. And that kind of blurred it for everyone because everybody had some kind of pain. And as Maria also pointed out, you cannot compare pain. It's hard to know whether your experience is the same as somebody else's or whether your pain reaction is different than somebody else's. So people or women were left in this doubt about whether their pain was severe enough or whether it was even a symptom. Another factor that also contributed quite substantially, or in at least in this research, or made it hard to seek care for menstrual pain was that everybody, or not everybody, but a lot of young women in Denmark use painkillers and or hormonal contraception to regulate menstrual experience. And that's fine. I'm definitely not saying that you shouldn't do that, or we shouldn't do that, or we shouldn't give this like pain relief to everybody. But the fact that it is so common, that it's used in general to regulate menstruation, blurs the severity of symptoms for the endometriosis patients, because they have to take hormonal birth control or painkillers to deal with their periods. And the other ones might not have to, but it's better for them that have, or they might have to a lesser degree, but it's not as necessary. So it's hard for the endometriosis patients to see, oh, I'm taking hormonal birth control and painkillers to have to even be in my body during menstruation. Oh, but everybody else is also doing that. So it's probably normal. So it blurs it. And here I also brought a quotation from an interview with an endometriosis patient who told that she had to continuously always take painkillers to endure her menstruation. And that was just the way it was, and it was considered completely non-worrisome. It wasn't thought of as indicating that she had some kind of disease. Okay, so that's menstrual pain. doesn't lead to a diagnosis. But what about symptoms in general? So this I've kind of said that the endometriosis symptoms and common healthcare strategies, at least in Denmark, and you'll probably recognize some of them, but maybe not all. But anyway, the relationship between endo symptoms and healthcare seeking strategies is a bad romance. It doesn't work. It's a terrible relationship. They should absolutely break up. But unfortunately, this is what we have. So what I mean with healthcare seeking strategies is the criteria we use to determine whether something's worrisome. So one of the criteria we use in Denmark often to determine whether we should go to the doctor with something is the duration of what we're experiencing in our body. So if the symptom or the bodily experience keeps going or it's enduring, we will assess it as worrisome. We'll be more likely to go to the doctor. The problem then is that endometriosis symptoms are cyclical, or at least among young sufferers and early on in the disease, for many, it's cyclical. And that obscures when to go to the doctor. So here I brought a quote from Anna, who's also an endometriosis patient, who says, so when I started vomiting from it, so that's the pain, at that point, every time I was on my period, I thought, this can't be right. But then it was kind of like, when I was not in pain anymore, I thought, oh, well. And then when it came back, I again thought, oh no, this can't be right. So she goes kind of through this cycle of being like, oh, this is worrisome, I need to go to the doctor. Oh, but then it passes. Then it's probably not a problem. So the cyclical nature of endometriosis symptoms is in direct conflict with some of the usual ways we use to figure out whether something's a problem, a medical problem. The next part is that endometriosis symptoms have a tendency to quite slowly worsen. They're not like immediate onset terribly worsen. They can be, and some patients experience, for example, like quite significant cyst rupture, but that's then very obvious for them that they have to go to the doctor. It's a lot easier to go to the doctor when a bodily experience is very distinctive and has a sudden onset. You're like, oh, this is a huge change. This is probably not good. This feels wrong. But endometriosis symptoms gradually get worse and worse. And so in the beginning, it might be like something that you're like, oh, this is kind of annoying, but not maybe a huge problem. And then it just gets worse and you don't notice how bad it's getting because it's slow, the slow gradual worsening. So this patient, Dita, is having quite significant pain with intercourse. And she started out as she's always had some pain with intercourse, but over time it really worsens to a degree where she's actually having quite a lot of difficulties having sex, or she can only have sex in certain positions. And that also shows that patients, when symptoms slowly or gradually worsen, they adapt to them. And that also deters healthcare seeking because you just learn to live with it. It's just terrible, but also a really unfortunate factor about how we often think about our bodies, or how we often think about healthcare seeking. The third thing I want to highlight in terms of endometriosis symptoms problems is that the symptoms, or we often go with things that are provable or visible in some way, measurable. So here is Maria, who's got some new symptoms at some point in her journey, and she could suddenly see them. She got blood in her urine, and that was very visible to her. She had like some kind of proof she could take to the doctor, and she felt she could be believed. So many endometriosis patients experience different forms of pain, which is invisible and non-measurable. And that's a problem for healthcare seeking because they don't feel like they have a symptom they can show off, and that's obviously being taken seriously. So to sum up, well, healthcare seeking with the early symptoms, which is menstrual pain, and also like before symptoms become constant and extremely bad and all of that stuff. So for the young patients, typically is quite complicated by a lot of social factors. So for example, that menstrual pain is normalized, that menstruation in general is regulated with different forms of medication, that symptoms are cyclical, symptoms gradually and slowly worsen and the patients adapt to them. And the delay is also worsen, or healthcare seeking is also complicated by symptoms not being measurable or visible. So that's what I had for you today. Thank you so much for listening.